Hello, everyone. Good afternoon. My name is Trina Shanks. I'm a professor at the School of Social Work and Director of Community Engagement. These calls on Thursdays have been hosted by the Engage team. We've been shifting to discuss equity issues in social work practice. And we've actually evolved from equity issues within COVID-19 as a way to kind of provide replacement field hours in this pandemic to actually responding to the uprising in support of Black Lives Matter and all of the police violence and brutality that's been existing and on display over the last few weeks and actually over much of our country's history. I'd like to start by introducing the Engage team. We have Aisha Ghazi Edwin, Fatima Salman, Sonia Harb, and our field intern, Jamie Simmons. And often helping us has been Dominique Crump. So thank you to all of you for all the work you do to make these webinars happen. Our call today is really emphasizing and reminding people that the work we do with individuals, such as clinical practice work, is an important part of actually also moving social movements forward. So we're talking about equity in clinical practice today, COVID-19 and beyond. And typically therapists and clinicians are treating those who are directly impacted by the consequence of macro issues like poverty, racism, gender, violence, and other historic and ongoing trauma. And all of these issues have been exacerbated by COVID-19 and have exposed a lot of the inequities that exist in our country. So next slide. So I get a chance to introduce you to the presenters who are going to be on this call today. We have Daicia Price. We have Andrea Smith, we have Rick Barinbaum, we have Sophie Skochelak, and then Dominique Crump is coming at the end to talk about self-care. And at the end, we'll give you all sorts of reminders of things that will be coming up in the near future. So now I'm going to ask to go to the next slide, and we'll have the opportunity to introduce you to Sophie Skochelak. She is, I want to make sure I get this right. They're just going to be talking about various innovative things that she's doing in interpersonal practice. And I'll give her a chance to introduce herself. She's a current MSW student, and we'll be able to talk about a lot of the work she's doing at the moment around COVID-19. So I'm passing the baton to you, Sophie.
Thank you. Yep, my name is Sophie. I'm an MSW student doing interpersonal practice and specializing in health. I'm actually currently speaking to you from Mott's Children's Hospital. I'm currently at my field placement. I'm in the neonatal ICU. And there I am. And I really enjoy practicing here, but when we started having to quarantine, all the students had to leave the hospital to reduce the spread of COVID among Michigan medicine patients. And so a bunch of students got together, both med students and social work students, and we worked together to create accessible virtual programs for Michigan medicine patients to prevent social isolation. So if you want to go to the next slide. So the first program I'm going to talk about, I am the social work student coordinator for, and it's called MedConnect. And the great thing about MedConnect is it started as a bunch of medical students got together and were talking about trying to help the COVID-19 patients within the hospital system. And during their conversation, they said, hey, wait a second, we need to maybe address needs of the patients from all sides. So they invited the social work students to be a part of it. And the goal of MedConnect is to provide clinically stable COVID-19 patients with a virtual med buddy to provide continuity, social support, and a point of contact during their time in isolation via phone or video chat. And that was really great. It was a great idea. And however, it kind of turned into a bigger, as it started, it just kept getting bigger and bigger as we went. And now what's amazing about it is we've adapted it even as COVID-19 patients have reduced in the hospital. So MedConnect started as a way to break up isolation for people who were going to have alternative housing. So those were the COVID-19 patients who were going to the hotels or the dorm rooms and wouldn't have had access to any supports whatsoever except for medical staff. Unfortunately, we didn't get too many referrals during that time. So then we adapted the program to include people who were discharged by outpatient and would go home and isolate at home. It was a great idea. However, again, we only got one referral. And so we then readapted the program and to include inpatient. And that's where we saw a really big, we got, I think we got like 5 referrals within a week of changing it over to inpatient. And it was really amazing because what we were finding is that these inpatient folks were just really looking to somebody to, just talk to. Because a lot of the time, of course, the medical staff is very busy, especially with the reduced amount of staff they had. And so what we did was we set up calls with them, and they would have a med student and a social work student. And the med student would essentially track their symptoms and make sure that if they were not feeling good or they couldn't breathe or they had questions, they could direct those to the medical students. While the social work students, and they also provided companionship, but the main point of having social work is that we were there to also help with any mental health issues that may be happening and provide just companionship and somebody to actively listen to their story. And when they're in the hospital and when somebody's, diagnosed with COVID-19, they have an increased risk for experiencing social isolation, generalized anxiety, and developing other negative mental health outcomes. So we are really there to mitigate some of those effects. And so in the beginning, we also screened for social determinants of health. So we screened for food, housing, utilities, transportation, interpersonal safety, and social isolation. Now, if they screened for any of those, we would red flag it. They would send it to me, and then me and my supervisor, Nora, would work together to then connect that person to a licensed professional and make sure that it got addressed. We got amazing response from it, and it's been a really great opportunity. And another thing that was really amazing about the program is it was an interprofessional collaboration. So as being specialized in health, I talk a lot about integrated healthcare. And what was really amazing is we had med students and social work, and we had those integrated together. And by doing that, we're building bridges with new generations of medical and social work students. The other thing that was really great is because it was student run, we were incorporating the voices of the next generation. And so that was really, I think, rethinking the ideas of what maybe our generation may value. And so it's been a great program to work for. And we've gotten good responses from it. Now that COVID-19 is right now reduced in numbers, we actually adapted the program to also include people who are just inpatient and sitting in the hospital. And we've already gotten 3 referrals from people who just need a companionship in the hospital and maybe don't have as many social supports. The other program, if you want to go to the next slide. So the other program that I'm a part of is Stay Home, Stay Connected. And it's an online pregnancy support group and educational group. So that, again, started with a bunch of med students. They were calling the pregnant patients of Michigan medicine. And they found that there's a significant increase in anxiety and depression. Imagine that, not being pregnant and not being able to leave your house. So I feel like it can be kind of obvious that there's going to be a lot of anxiety and depression, but what they really were looking for was just community, which they had lost by not having that normal pregnancy journey. And so there was a little bit of loss and grief towards that, losing that normal pregnancy. And so they created this program to address some of those barriers to feeling like you're sharing your journey with people. So the program that provides a supportive community of 8 to 10 fellow pregnant individuals at similar stages of pregnancy. They have a private Facebook group for sharing information and experiences. They have monthly online discussion topics. And then they also have small groups. So the goal of that was the large groups are the educational portion, and that may be labor and delivery, doula services, breastfeeding, whereas the small group is more of your support group, and that's when the 8 to 10 individuals would get together, and a social work med student and then a licensed provider would all facilitate the group together and answer any questions that these patients may be having. And really this was created because it's due to like fewer in-person visits, more remote monitoring, and it was just a way to share your journey. So again, what was amazing about this group, and it's still going on, is that it's, again, a collaboration between social work and med students. So it's this great journey of interprofessional education for social work interns. And then also it's kind of a holistic approach to virtual telehealth, like virtual telehealth. And that's because these patients are able to talk to social work, medical students, midwives, OBGYN providers, and doulas, and lactation consultants all in one community, rather than having to go to separate appointments. So those are like the two that I'm working with currently. I'm trying to start another group, and that's more student-based, and I'm hoping to get my internship cohort together just to talk about the student experience and share with each other our own anxieties, because as students, we also have to hear each other. So those are a few of the projects I'm working on.
Thank you so much, Sophie, for sharing. I think it's amazing the work that you're doing and helping to lead with students. And I'm glad you really talked about how integrated care is really the basis for this work, right? Yeah. Because they found that, people we know are complex and multifaceted systems. And so does the care that they get needs to be the same way. And that the more diverse the background of the team members, the better the health outcomes. Mm-hmm. So thank you for really speaking to that. So I want to open it up to any questions from participants. And I want to lead with a question first for you, Sophie. So how are students involved in this, and can they get involved in this now?
Currently, it's really just the Michigan medicine cohort, just due to needing, it's a kind of an insurance liability, and we have to sign certain forms being a part of Michigan medicine. But it's definitely like MedConnect is a super adaptable program that can be started in other health systems. So it's not something that can just it's not a program that just stays here. It could be adapted very easily.
How do you feel your education as a social worker in this program has prepared you to work in an integrated care setting and working with clients who are experiencing crisis, right?
Yeah. My education has been great, just that they've given me some of the basic building blocks of working with the patients directly and working on those skills that were taught from the beginning. And that includes just walking. A lot of it was when we were calling people during MedConnect, it was just picking up the phone and saying, how are you doing? This is a lot. And normalizing that experience they were going through, because they're like, I'm so anxious. I can't, this is so crazy. And it's like, it makes sense though. And this is very normal that you're anxious. So let's, and it was really just listening. And from the beginning of my education, all of my professors, including you, Aisha, have all said, listening is such a tool to be used in a medical setting, and to really just say, I'm here to meet your needs and to listen to your story. And sometimes we were on the phone for like 2 hours because some folks just said, hey, this is my journey, and I need to share it with you, and I need somebody to listen to it.
Mm-hmm.
And I think that from the beginning, that's how my education has always started, with, active listening and meeting your client where they're at. So, and also, fortunately, my internship is also medical, so I know some of the medical jargon.
Right. So we have a question here from Trina. What have you learned from this experience? Is it true that the hospital system is no longer overwhelmed by COVID-19 patients? What were various phases that you saw the hospital go through?
Yeah. What have I learned from this experience? I feel like that's a part of like seeing the phases, in the hospital. From this experience, partially it was just, I've always been so like in person in a lot of the work that I've done previously. And it was really interesting to provide telehealth and like talking over the phone, because it was learning these new skills of like using inflection and using like a lot of motivational interviewing to really like work with the folks over the phone and make them comfortable with you. Because a lot of times when I'm working with patients in person, I use a lot of body language to really try and like relax them. It was also, in this experience, I did a lot of mindfulness and breathing exercises, and that really helped a lot of folks over the phone. Through the hospital system, I was here almost till the day that they sent the students home. And that was a pretty amazing thing to watch as a student, because I saw how this big institution, this big essentially business, was slowly shutting down and trying to, it was every day there was a new policy. And so I always like to talk about how like micro, macro intermix so much. And it was like learning a policy every single day and then learning how that happens and how that affects our patients and social work and the nursing staff, and watching that process and learning about like the policy process. And yes, we are no longer overwhelmed currently with COVID-19 patients. We actually just closed our RICU down. If I remember, it's like regional, I can never remember the I, but it's where all the COVID-19 patients would go if they needed to be hospitalized. So the RICU has been currently closed, and they did reopen it as the normal floor that it used to be. But what's great about the hospital is everybody is truly trying everything they can to be safe, and they're wearing their masks, and we're putting on our hand sanitizer. We're washing our hands almost every hour. My hands are slowly peeling away.
So, we have another question here from Angela Johnson. So these are great programs you describe. What programs and services are available that are more community clinical focused, less patient focused? So I think that means more kind of clinical or community based. Do you know of any that are doing similar work in the community?
Not that I know of. If we flagged for a social determinant of health, we would refer to a licensed social worker to make sure that the patient was getting what they needed. And I just also wanted to say that it's regional infection containment unit. But not that I know of. I know if I like gave anybody like a number, I actually used the list from like the big compiled list that you guys made. And I would refer them to that. And I say, hey, look at this website because this has all these numbers on there. And our patients would look at it and they'd say, oh my gosh, look at this compiled list of information and resources. This really helps me. And it helps us too. When we're like talking to the patient, we're like looking through the list to see if there's any numbers that we can access. But unfortunately, I don't know too many specific community clinical focused.
Mm-hmm. I know that there's various efforts that the Engage team has been tapped into. And if you visit our, list of volunteer opportunities, it has some of those. Like Center for Independent Living has started an initiative where they're calling, the elderly patients that they used to work with and just checking in on them. So I want to ask a question now by Dominique Crump, which is great. And I think it really speaks to kind of the equity issues that we need to confront in clinical practice and medical practice. So the question is, thinking of the demographic of patients at Michigan Medicine since this project has been launched, has there been any tracking or noticing of who is accessing these services? More specifically, thinking of how many folks in the Black community, not all, but this is a thing, have had a history of mistrust due to harm caused by the medical field. Have individuals with varying identities been accessing the service, or does it tend to lean toward a certain demographic, e.g., younger, older, certain race, sex, gender, etc.?
Yeah, that is a great question. I'm going to answer it the best that I can, just because there is a project through MedConnect that is tracking the demographics. I'm just not a part of it, so I can't completely speak to all the demographics. From what I've seen, it's been all ages. I've seen as young as 25 and as old, I think somebody was around 90. We have been getting people from the Black community. Specifically, I did work with somebody who was from Detroit, and that was a really eye-opening experience. Because Detroit has been affected so disproportionately compared to other people. But I can't really speak completely to the demographics, because I haven't looked at it as much as a lot of more the policy side of it. I can get back to you, though, if you would like me to.
Yeah, I think that would be great. And I think it would be important, in whoever you're working with and in tracking this data to think about, we know the Black community is disproportionately affected, and we know that they've been traumatized by the medical field. So what are you guys potentially doing to reach that community and to bring them into getting these services, considering that they need it more because there's higher numbers? So that'd be interesting to hear about. So yeah, any information you could bring back to us, we'd love to share it.
Yeah.
So thank you, Sophie. I know you have a clinical issue that you're going to also go tend to right now, but I want to thank you for joining us, even from the neonatal unit.
Yes. Thank you. Sorry, I have my supervisors that's messaged me with that we'll be having those discussions real soon, so that we can get back to you guys as soon as possible.
Yeah, we'd appreciate it. Okay, thank you.
No problem. Thank you.
So Fatima, you can go ahead and go to the next slide. Yep. So it's my pleasure now to introduce two amazing clinicians who are doing really innovative work in the field of clinical care, and their work has always been focused on issues of equity. So I'd like to introduce Daicia Price, who's a clinical assistant professor here at University of Michigan. She's also a clinician and a consultant. And Andrea Smith, who is the Director of Workforce Training and Program Development with the Detroit-Wayne Integrated Health Network. Thank you so much for joining us.
Yes.
Take it away.
Thank you. So we'll just start right away with our next slide, since we are glad that people can see us. Maybe we should have kept that slide up as our picture while we talked. So we are going to talk with everyone about a very innovative project that started called Reach Us Detroit. And as it says on the screen, it's an effort to deliver 24/7 collaborative virtual therapy. And it's a call center to support young people age 14 and up and families. We started on May 20th, and we're going to pilot through December 31st. Our primary focus is to instill hope while focusing on identifying strengths and resiliency in individuals who are often underrepresented and have difficulty engaging with behavioral health treatment. So like we were already introduced, we like to say we've been doing this. This isn't new to us. It's always been something we've been passionate about. So we're excited that this gave us an opportunity to do something new. And I'll let Andrea talk about how the idea came up in the middle of the night.
Thank you, Daicia. So yes, Daicia and I both have this habit where I say we, so I'm going to just do that. We both tend to work better at night. That's when things are kind of winding down and you're able to think more and focus and you identify gaps in that way. And so someone reached out one night and said, hey, do you think that if we gave B1 some money that you could launch a virtual therapy line? I said, absolutely. So I didn't know how. I didn't want to, chance it and say, well, what do you mean? I didn't ask any further questions. They sent me a link on, where they got the idea from. And I immediately sent it to Daicia and said, hey, check this out. Let's look at this. And we went to running and got it launched in about 3 weeks. So the idea came from Andrea Cole specifically at the Flynn Foundation. And she was looking at the time at the high numbers or disproportionate rates of African Americans who were being diagnosed with COVID-19. So at the time, we saw that while African Americans make up 15% of the state of Michigan population, they were representing 35% of people diagnosed with COVID-19. So that reflected that African Americans in Michigan were 133% more likely to contract the virus. And so the death rate was, increasing. And we looked at this and said, what can we do? Because that you have people who have to be anxious over this. They have to be, wondering and worrying, why is this happening to us? So we wanted an outlet that individuals could utilize that was basically an unconventional setting where it's not sterile. And that we're addressing people that look like you and we're offering services directly for you. So African-American males are one of our highest target groups. And then as they just stated, adolescents, because these are the people that we're missing. So, females are more likely to get help, but we want the males who would normally not think about it at all. We want you to text us, call us, email us, chat with us. And the same goes for adolescents. And I can go on for days about that, but I'll just wait. And so we'll let Daicia go ahead to the next slide.
Oh, did we lose Daicia?
Sorry, I muted myself. I said that we're approaching the line and the callers in the same way. So like what Andrea said, when she was approached with, this is the challenge. One thing about Andrea, I just want to say I do not work better at night at all. I'm actually a morning person. But when problems are presented, instead of continuing to talk about what is the issue, talk about the water while people are drowning, we like to think about what are some solutions. So you can go on to the next one because there's a couple of quotes that we want to share. One is from the Detroit Way Integrated Health Network President and CEO Willie Brooks Jr. And he says it's a remarkable partnership. I'm grateful that other organizations share our passion to reach out to young people and families during these unprecedented times as we try to get a handle on the impact COVID-19 has on our young people. And we have one from Andrea Cole. If you go to the next slide, these were in our press releases about the project. And she's the executive director and CEO of the James and Ethel Flynn Foundation. We never experienced before. We're facing so much uncertainty, and we shouldn't have to do it alone. African Americans have been hit particularly hard. This is a trying time for all of us, but especially for young people who may already be struggling with mental health issues such as anxiety, depression, suicidal thoughts, hopelessness, and substance use disorders. So again, it was issued as a press release right before we started in May, and we are really excited to be providing this service. And as I look at some of the attendees, some of my students have been exposed to some of the training that it takes to get a software and website put together. People are coming into our thing, website together, and really learning how to do something from scratch. Because when we looked at other entities that were doing something similar, it was really a call center that then people could leave their information and then get referred to another therapeutic space. And we wanted to have an opportunity where as soon as people call, they could get directly connected to a therapist right then in that moment. So we have 4 different providers that are collaborating to offer the licensed clinicians to provide the therapy services throughout the day. And so they're all Detroit Wayne Integrated Health Network providers. You can go to the next slide. I think the next slide is my favorite slide. Yeah, okay. You all see that picture? Andrea mentioned that we are being very intentional about the people that we're trying to reach out to. And so for some of you all, you see those fellas in that picture. I'm sorry if you're on the phone and you can't, but that handsome fella in the baseball cap with the D, that's my guy, my husband, the one and only Mr. Price. And so again, trying to get something up and running in 3 weeks is not an easy feat. So you pull on the resources that you have, but we also consulted with a lot of Black men to say, what do you need to see? One of the things that we saw is that they said they didn't want to see therapy lines that seemed like it was depressing and sad and sterile and flowers and rivers, and they didn't want that. So they talked about you need to just show people who look like me, regular people, and that's what we did. And so we've been really excited to really focus on being culturally responsive and acknowledging the fact that people have identities that are intersected. You want to add anything to that, Andrea?
2 of those 4 are my brothers, but that's it. That's it.
I think it's important to think about when we're talking about doing innovative things and being culturally responsive. I encourage new professionals to really consider, how do you build a network? And as social workers, sometimes you can sit and wait around and wait for somebody else to do something, or you can link up with people and do things collaboratively. And I think that shows the importance of connections. And I always take every opportunity I can to tell people that Andrea used to be one of my field students when she was a young undergrad student. And so having those connections that you can continue to impact the world with in different ways and not wait for something else. You go to the next slide. I think that might be our last slide. Yes, so that's a little bit about Reach Us Detroit. Again, we do the texting. It's been very interesting. As we mentioned, we are collaborating with other organizations, but until we could get contracts and all of those wonderful or not so wonderful details solidified, you're looking at the agents and some of the students in the field, and the HRSA scholars and Detroit clinical scholars. I just call them and say, I need you to take a call now, right now. And so I just want to give a shout out to Chelsea and Tony and Justin. And I might miss people that I didn't see in the list, but yeah, it's just been amazing to see the students also be engaged in this work.
I want to thank Andrea and Daicia for sharing this amazing work.
Thank you.
Thank you guys for being these change makers and these leaders. And I want to open it up to some question and answer, but I want to lead with a few questions that I have for you guys. One is, how can non-Black clinicians make a more equitable clinical practice? What's missing right now in terms of delivering interpersonal care to clients who have experienced the trauma of racism and discrimination?
So one of the things that people may have heard me say this before, but I definitely encourage people to think about how they can impact other people who are not of color that have also been impacted by racism, to help them unpack the things that they're experiencing, because oftentimes they perpetuate negative emotions, feelings, behaviors on people of color. And also feeling very comfortable in either having a conversation with people about race, like not ignoring it, but really opening up the therapeutic space or community space to talk about it. I have recently had some of my colleagues that are white colleagues offering connections to their Black clients that's outside of the therapeutic relationship. So let's say their client works at U of M. They'll reach out and say, what other resources are available for my client to get additional support from people who maybe have similar experiences, but still maintaining the therapeutic relationship. So not thinking that you have to be the end all be all. You can talk about it in sessions, but also demonstrating that you want to make sure they have external supports can be really beneficial. And again, not feeling like your need is to go and support people who've been impacted by racism, but to also be a change agent with people who are racist and have those ideas within their minds that are really harmful to themselves and others.
Right. That's great. So we have a question from Angela Johnson. I have strong connections with Detroit organizations that serve African-American mothers and families to support birth and breastfeeding. I'm happy to connect you. So it was more of a comment.
Yes,
Sure.
Angela, please do.
That's wonderful. We'll help you guys get into touch.
Thank you.
So another, question that I have, and this is something that came out of an ABSW meeting that I attended that a student brought up. And when they said it, it really hit me. They said, when we talk about interpersonal practice and we have these interpersonal practice classes, we always have some part of the class that talks about working with diverse, multicultural clients. But we never talk about, how do you confront clients who are racist? What do you do when you have a white client or another client who have racist ideologies and beliefs? And we know that racism is a public health crisis. So it's definitely relevant to our work. Can you guys speak to, how do you confront it with your clients? It's a lot.
Well, okay. So I should have wrapped up the first answer with saying that I think that that's one of the biggest gaps that we have in our educational programming, is that it's so focused on how to work with other people that it's not thinking about, how do I work with people like me and how to face some of the challenges that actually create the structures that impact people, right? So that part is really absent. So what I have done and have been fortunate enough to do is try to really recognize my own identities and how some ideas of white supremacy and white supremacy culture have been embedded in just who I am and how that's impacted my ability to grow, and recognizing that human behavior in a social environment is not only unique to people who are marginalized, impoverished, any non-dominant identities, but it's human behavior in a social environment impacts everyone. So when I'm working with people who have been impacted by their environment, I have to look at them as individual people. I used to work in Ann Arbor, and so I have had many clients that were racist. And when I worked with, everybody knows, well, some people know that I feel like everybody who's not Black, person of color is racist. So whether you intend to or not, your profession is racism. So whatever. Recognizing, because I feel like racism is a systemic thing. So but I'm talking about overt racism, like, no, you can't come in my house. No, my husband doesn't want me to talk to you because you're Black. Oh, calling me out of my name. When I work in spaces that are public entities, I really worked on trying to get people to see, like, what are your thoughts about this and where does that come from? And then just saying, like, I recognize that that's your reality. What can we do to work together? And sometimes, if possible, I have had to say or try to see, would there be other people that will work better with you? And referring them to people that I think they could develop a rapport with, because I don't want that to get in the way of what work they need to do. I have also done things in community building with clients who, because another thing, we talk about intersectionality, we talk about it, and then we have to think about what are some of the other clients' challenges that I've worked with. So when we talk about people who have lack of access to education, lack of access to financial resources, oftentimes those individuals have a hard time understanding the concept of race and privilege dynamics. And by providing community education in the roles that I work, so I'll do a group about self-actualization and identity for clients so that they can understand what's happening and try to think of what can we put into place to support people, to work with people that look like me. So I guess a long, short answer. I think in the beginning, it was really hard for me when I was younger, but I think the more that I've been able to understand that people are just a product of their environment and systemic mess, and that they're just as negatively impacted as of course it impacts us in different ways, but it's awful that they have that they walk around like that. So.
Yeah, that's great. I like how you bring up the point that we have to really view people as products of their environment. Mm-hmm. And remember that white supremacy is harmful to all of us.
Yeah.
Andrea, do you want to add in?
Yeah, no, just one point. I think a good example of this was in the UK, where there were some protesters for the Black Lives Matter movement, and there was a counter protester, and he was at risk of being harmed further. And these Black males picked up this white individual and carried him to safety, even though they were on different sides of the topic at that point. It's important to remember that we are all human, and when you see someone in need, then you help that person in need, and you put those differences to the side to get for the greater good. So the goal, we can't change anything if we're not willing to move forward and put these personal feelings aside and look at the larger goal.
Thank you so much. So we have a question from Kaylin Cobb, and I apologize, you guys, that is my doorbell in the background. So the question is, I know that you are working on making connections with other organizations, but do you see Reach Us Detroit continuing past December? Are there ways we can support your work?
Sure. So right now we're looking at it in a pilot format to see how much impact we actually have, or how many people call, how many people text, and what does it actually take to run a line like this 24/7. So things are going smoothly, and if they continue to go smoothly, we would like to extend past December, but we don't want to put something out that isn't needed. I think it's needed, but connections to other organizations that can help spread that word and can help let people know that we're here can definitely assist us with carrying this forward past December. And so I ask a question to the person who asked, who is the us necessarily? Is connect with whom exactly? like organizations, individuals? What they say, are there ways that we can support your work with the we?
You know, it does not say. I think Kaylin Cobb, it doesn't say, but it says, is there a way that we can support your work?
Okay. Well, referring people to us.
Referring people is a way to support.
Absolutely.
Yeah.
And I'll also answer some questions that came in, just chatted them in. And so we said Detroit, it's called Reach Us Detroit, but the line is open for everyone, anyone who lives, works, plays in Wayne County, or worships in Wayne County. And those are the things that the funders asked for us to focus on. And that's why they partnered with the community mental health entity in Wayne, which is Detroit Wayne Integrated Health Network, just for in case people don't know. They're the overseeing body of public behavioral health services in Wayne County. So it doesn't reach out to Washtenaw. I'm sure that if Washtenaw or any other county wanted to do certain things, they could also do that. But again, the funders that we're working with were particularly concerned about how COVID-19 had impacted the residents of Wayne County specifically.
And just one thing to add to that, we won't turn you away if we find out you're from somewhere else when you call. We would still try to connect you with needs or resources in your local area. So we have had calls from Oakland County as well as Monroe, and we do handle those calls, but the primary focus is the city of Detroit and Wayne County.
Yeah, I think I put in the box, we screen in, not screen out.
It's a good way to put it.
Mm-hmm.
Well, I want to thank you guys so much again. It's amazing the work you're doing. And please, send us any information that we can share with students or put up on our page. We'd love to generate more traffic to you and get out the word.
Thank you.
Make sure you use the picture with my husband. Trying to get him to be a model somewhere.
And he is on a billboard as well. Yeah.
We do have two questions quickly that I just wanted to ask of you guys. One is by Sarah Fisher. Development Centers has a very active Head Start Dads group, and I would love to share this resource with them. Okay, so Sarah, you're asking what info should we give them?
Sure. So I would say give them the website as well as the phone number. Phone number is 313-488-HOPE. And Development Centers is one of the partners that provide services on the line. So you can just reiterate that so they'll know that it's connected.
And for the other question about referring patients from Detroit, I think that's Detroit Receiving Hospital. It would be really good for people who need more brief intervention, so up to like 12 sessions. If it's someone who would meet criteria for having a severe emotional disturbance or a severe and persistent mental illness, then what we are doing, if they need more than those 12 sessions or so, we are connecting them with the access line, doing more of a warm handoff and connecting them with providers such as development centers, Starfish Family Services, Hygera Health, and who did I forget? And the Children's Center.
Okay, amazing. Thank you so much again. And you did say that students are actively involved in this initiative and helping you guys.
Yes, they are. Yes.
That's amazing. Okay, so we will make sure to share your info with everyone. So Fatima, if you want to advance to the next slide, it's my pleasure now to introduce to everyone Rick Barinbaum, who is a clinician. He's also a lecturer at the School of Social Work. He's a field instructor, organizational consultant, and he has an interprofessional focus, and he works with a variety of populations. So I'd like to welcome Rick, and you can go ahead and take it away.
Hi, everyone. How's it going? It was really great seeing that presentation. Daicia, I like going after you because I would follow you anywhere. I'm going to quickly talk about who I am in my work, and then I'm going to talk about the community that the Pinckney Clinic is, the University of Michigan student-run free clinic. And then I'm going to talk about COVID, and then I think some issues around equity, and also some one instance of overt racism that we experienced. So just to give you my background of where I came from before I was in Michigan, I lived in New York City for about 15 years, and I worked for an organization called the Center for Family Representation that represented parents that are accused of abuse and neglect. And so it was interprofessional with social workers and attorneys working together with parent advocates, people who've been through the system and gotten their kids back. And in New York City, I mean, that meant that almost entirely all the people that I worked with were people of color. I don't say this to say that like I'm the wokest person in the room. If anything, the opposite. I probably microaggress 4 times before breakfast. But the place where I work now is very different. So I was in New York City. I moved with my family here to Michigan. In the beginning, I was doing some consulting work with an organization in Texas that represents families separated at the border, again, helping them build out a program for social workers and lawyers working together. And then I shifted to working at the student-run free clinic where it's still interprofessional, but it's focused on integrated medicine. So the reason why I talked about my background is that the University of Michigan is in Livingston County. Oh, next slide, please. While you're doing that, I have a feeling that my kids are about to interrupt this and appear on the screen. So this clinic is a student-run free clinic. It's interprofessional, meaning there's students from nursing, pharmacy, dentistry. There's some students from public health, students from medicine, and recently students from social work. So it started in 2012. It's a model of interprofessional learning, and it's in Livingston County, which is frankly a very, very white community. I mean, I was looking at some statistics. I feel like 95% of, or maybe it was something like 99% of the people in Livingston County are white. That's not to say that there aren't people of color there. So recently, as of last year, we started having social work at the clinic. So in some ways, the student-run clinic, while it is a good educational experience, it's also a great, I think, example of the structure that's built to address equity, meaning people that are underinsured or have no insurance. And so in Livingston County, there's about 15,000 people who live below 125% of the poverty level. Almost 9,000 people have no health insurance coverage. So those are the folks. Switch beat. He's putting his shoes on. Yeah, that's good. And it's within this community, it's Livingston County's only free clinic. And so 20% of the patients use that clinic as their primary care, although that's not the idea. The idea of the clinic was to, I think initially is to get people great medical care, address their needs, but then also transition them to programs where they can get insurance. But there's a lot of folks that don't fall into that category, where they just can't get insurance. So at the clinic itself, I'd say about 90% of the patients are white and about 10% are people of color, usually Latinx, quite a few folks that speak Spanish. And this is some pretty old data, but about 35% of the patients have some sort of behavioral health condition. And so you see a lot of anxiety, a lot of depression, ADHD, some pretty severe substance abuse disorders. So it's a good resource for members of that community that don't have access to healthcare. And I can say that I encountered a lot of people that have gone a really long time without ever seeing a doctor, like 20 years. I met 3 people that had almost never been to a doctor outside of when they were kids, and they're coming to the clinic because they have, something that's happening that's preventing them from working, a mass that's growing, some pretty crippling mental health. And to give you a bit more context, and so I teach a course that's the Interprofessional Education Experiential Seminar. And so students come to the course and they meet 5 times throughout the semester with me as a group. And then at the actual clinic that meets on Wednesdays and Saturdays, each student participates in the clinic 3 times. So this summer, a number of students stayed on and have just been volunteering. So they're not getting paid, I'm not getting paid, but we're there still trying to deliver good service for those patients. Next slide, please. So what do we do? It's integrated behavioral health. And so what does that mean? I think that my favorite way of, I'm gonna use my mouse, of explaining it is that, like, if medicine's job is to look at a presenting issue like this, our job is to zoom out and look at everything going on around it. And so I think Sophie was talking about social determinants of health. I think that pertains to mental health. I think it involves looking at structural inequity. So what does that mean? Brief interventions. So in person, how the clinic worked is that if somebody came in and there was something going on that we could see that social work would be a benefit. It could have been because of mental health. It could have been because of poverty, because of food insecurity, any number of things. And so if we know that, then the social worker would join the medical team and we'd interview the patient at the same time. And when I say we, it's the students. I precept in the back. So the students talk to the patients, they come out, they come and see me. I prefer, I'm gonna keep going. I was about to go down a rabbit hole. So there's other times when the medical team is seeing the patient and then something would come up. Somebody just got out of a domestic violence relationship and they're a total mess. Again, some sort of social determinant of health, thinking of Maslow's hierarchy of needs. Oftentimes the social workers are looking at that baseline functioning and then going up from there. So at those times, social workers would come in and intervene with the patients. There was something that in Daicia and Andrea's slides that I think really resonated for what we do, which is like trying to take time for solutions, where oftentimes it's working with people in a state of crisis and not jumping into how we fix it. Another way of looking at it is that it's providing just clinical work enough so that the person sees the merit in talking to a clinician while we're able to refer them or connect to a community resource. So some more brief interventions, so crisis intervention and safety planning, behavioral techniques, and sometimes that can be, motivational interviewing with somebody who's in early recovery or pre-contemplative, like they need to start getting into recovery. Sophie said this, but I've been really impressed at the amount of students that have been really comfortable with stress management techniques, limited and targeted CBT, relaxation exercises, body scans, helping people through breathing. We do brief problem solving and solutions-focused interventions, and a lot of client-centered advocacy. And what I mean is making referrals for the patients we're working with, but not just giving them a phone number, but really trying to see where they are and what they're doing. So when COVID hit, everything shut down and the clinic shut down. So what we met as a team, meaning social work students at the time, obviously the semester was still going, and we said, what do we want to do? And so we started doing wellness checks, similar to what Sophie described, calling patients saying, how are you right now? And what we found is, people were surprisingly willing to pick up the phone at that time, despite the fact that all the students were calling using *67, so their numbers were blocked. But a lot of it was, again, asking about their basic needs and then having just supportive conversations and giving them a space to talk about what's going on, helping them identify their support networks and activating those networks. And that's been a very big reoccurring theme that I've seen that comes up. Initially, I think that we had a very interprofessional clinic, and then it largely split apart when COVID happened, just because there was so much going on. I feel like everybody was in a state of crisis, meaning practitioners, students, professors, clients, patients, etc. So over time, we've become more interdisciplinary, meaning now we have the clinic is opening somewhat where there's a medical student there, and then when a social work need comes up, sometimes they could do a video chat or a phone call with a social work student who's at home. We're doing a lot more communicating with each other about patient needs and trying to connect people to resources. Next slide. So I think that I talked through this slide. Let's go to the next slide. So I thought about how to talk about this particular webinar, like equity in practice and what's come up at the clinic. And so there's two things that popped in my mind. One is while it's a micro practice working with overt racism, and the other is access to help for undocumented folks. And it's interesting. A client came in and he had all sorts of health conditions going on. And he made a comment to one of the social workers about not wanting to apply for a particular benefit. And he made a comment saying something along the lines of, well, it's because all the Black people are getting it. And that was I think it was a challenging moment for the practitioner, But to take a step back and talk about from the micro perspective. So look, we live in a capitalist white supremacist system, and this is a person who's bought into a narrative of white racial resentment about their particular station in life, the idea that you look at the failures of the system to help you, and that you conveniently scapegoat other people around you. And it's not like this is just one person. I would actually say that he's in a universe that encourages that type of thought process. So what happened at that moment wasn't confronting somebody who was bigoted, but it was reality testing and just saying, so have you applied for this benefit? If you did, did you request an appeal for the denial? And just reality testing and breaking him out of that narrative and actually getting him to think and help himself. And again, zooming out to the micro issue, there's so many ways that this system, especially economically, fails everybody. And I'm not, by any stretch of the imagination, talking about trying to level the playing field and that it's awful for everybody. And thinking intersectionally, it certainly isn't. And this system does fail everybody and robs the humanity of everyone. I think that the grand challenge in that particular situation is that the social workers don't, for the most part, build relationships with the same patients. In my past, when I was in New York City, I worked with a couple of people that harbored some real racial resentment. And I tried over time as we built a relationship to undo it. And I was never successful at it. I mean, at the very most, I got them to not say certain things around me, but I was not able to crack that architecture that they had put up. And I'm going to say something that's probably not going to be satisfactory to anybody on this call, but I don't believe in deciding who's worthy and who's not worthy. And I don't believe that this guy, despite the fact that he harbored beliefs that make me sick, I don't believe that he shouldn't still be able to get access to care. And I think that he should get the same quality access to care that I believe that everyone should be able to get. And at the same time, I do believe that we should take efforts to break that down. Now, another direction that we went when we debriefed this in the class was really thinking about how students can support each other to make a safe space when this happens. And I want to differentiate between safe and uncomfortable. I believe that situation was uncomfortable, deeply uncomfortable, and I think that social work is a profession where we should be uncomfortable. I believe in competing tensions. I believe in acknowledging that social work is part of a racist oppressive institution, and we can do work at the same time that helps people. But I don't necessarily think that this is a moment that was unsafe. I could see how it could be unsafe to a person, but the conversation with students is how do we support each other when something like this happens? So that was micropractice with overt racism. I do want to name that despite the fact that Livingston County has a history of the Klan being there, the fact that there was in the same day a Black Lives Matter rally, and Second Amendment folks both marching around the same time, everything was fine. But I haven't experienced any overt racism there. I'm a white person, obviously. At the clinic, and frankly, there's quite a few students that have been there. There are people of color that wear head wraps that haven't gotten any sort of, that I've learned about, overt racism thrown at their faces. But I also wonder if part of it is that people are desperate for medical care and they're coming to that clinic. So I'm going to pivot to another situation that I think talks about equity in practice, is that there's quite a few folks that come in that are undocumented. There's one particular person who came in who was having stress issues, and he spoke Spanish, so one of the social workers sat down with him, and he had a lot of economic stressors. He was working in a restaurant, and he was really freaked out about getting help anywhere. He was afraid to call 211 to see who could help him with his back rent. And so there was two things that were going on. One was trying to address those socio-emotional needs, and it was the social work student who really made the connection between his physical health and his mental health at that moment in time, and that his stress, his very, very real stress, was exacerbating his physical symptoms. So part of that was referring him to the Michigan Immigrant Rights Center. So COVID hit, and he lost his ability to make money because the restaurant closed. So he reconnected with the clinic, and a particular social worker was able to find, through Worker an organization in Oakland County where he now lives that was able to get him money so he could pay some of his back rent, which was really amazing, just because it was a desperate time and he had no hope whatsoever. Sometimes I think it's a Band-Aid on a gunshot wound, because inevitably he's going to be running out of back rent again, and we'll be there to help him. But then there's another piece of this, which is just that, like, in the medical system, one has to be really careful about how you document somebody's status. You know, we don't ask people about their status just because we're curious, only when it comes to accessing resources and benefits. But we have to be careful. You don't want to put in the notes, this person is undocumented, because you frankly don't know the next person who's going to be there. And even if it's a remote chance, there could be a doctor that, would want to call ICE. Like, is that possible? Yes. Is it likely? No. But should we be very, very cautious to make sure that people that are here that are undocumented can get quality care? Yes. So I know I talked really fast, but that's what I wanted to present to you about the clinic. And if any of you are interested in taking the clinic, I think there's still spots for next semester.
Do you want to go to the next slide, Rick?
Yes, next slide.
Okay, so I want to thank you. I think that you highlighted the work that you do really shows the intersection of policy and micropractice, right? And how important it is for IP students to know about pertinent policy issues and also know how to respond accordingly. I also really, I want to open it up to any questions from the audience during this time. So if you have any questions for Rick, please go ahead and type them in the Q&A session. Oh, I think we have one. So we have one from Tony Bunton. I'm curious as to why Livingston County for free clinic. Any chance we can get a student-run clinic in Detroit? So I think the question, go ahead, Rick.
I can try to answer this. So I'm new to the clinic, and I don't know why Livingston County was identified as the clinic. I think part of it was proximity to U of M. But what does that mean? Because Detroit's 45 minutes away versus 20 minutes to Livingston County. I do want to name some realistic competing tensions around the clinic. I think there should be a free clinic in Detroit. And I think one of the challenges of student-run clinics, and this is a student-run clinic, meaning that the directors are students, the practitioners are students, and then the professionals, the old people, we're like in this tiny room, and we precept with the students and then provide guidance and oversight. But there is a dialectic, some competing tensions between the educational experience for a person and quality care. And so there are times in that community and other communities that they're very resistant to the idea of a student-run clinic, the idea that somebody's life is going to be a student's educational experience. I'm not answering your question directly, but I like highlighting competing tensions so we think about how challenging it is. And so you can see on the one hand, you could see a lot of support if someone's like, let's get a student-run free clinic in Detroit. And you could also see other people saying, wait a second, we're going to have these outsiders come into the community so they have a good educational experience. And so I'm not giving you an answer, but I think that it would be amazing to have a student-run free clinic in Detroit. I would definitely want to work there. And it's not so simple as, I think, just setting it up, because really you need to have a lot of support and buy-in from the community and navigating that tension of when something's student-run, just as all of you as interns, I'm sure, see this tension come up at time, when your educational experience is really connected to somebody's life.
Right, that's great. That's a great point. The competing interests, right? People's lives can't be necessarily just someone else's educational experience. So we have a question from Daicia Price. Andrea and I have discussed this. One of the challenges is that Detroit has federally qualified health centers that are accessible to all people, technically accessible to all people. So I think that was more in response to the question that was just asked. So yeah, that is a very good point. And then Andrea is just agreeing with Tony that it would be great to get some free clinics. So I wanted to know from you, Rick, what are some of the things that you see are missing potentially in the training or education that students are receiving when they go and they run these free clinics? Like, what do you think that they need to learn more about that they're not getting? What's kind of the learning curve?
That's interesting. I think that the place that I think it's two things. I want to make the clinic more explicitly interprofessional, because there's competing tensions there, especially as social workers, where, on the one hand, there's this dynamic, which is that, like, as a social worker, I'll take whatever comes to the door. And if I don't know something, I'm going to figure it out. And I feel like I've gotten very good at doing that. On the other hand, social work can be like the garbage dump for all people's problems. And that's a terrible term, but I feel like sometimes that's how partners can view social workers. Like, oh, let's give them this. I don't know what to do. Give it to them. Give it to them. And so I would like to see more training. And it's actually something I'm working on, is making it more, although it's a great interprofessional experience, really enhancing the interprofessional learning about fluid and discrete roles, about how we work with each other, about how we communicate, about how we respect each other, and about how we had that conversation, because I think that's one place that's missing. And then another is on engagement, and something that I'll see at times is that, like, the social work students are very good at engaging people with empathy and sincerity, and the medical students and nursing students and others, I think, pick up on it. But I would love to see more initial training on engaging with people. There's oftentimes people going to the clinic that are very, very angry. And I think that de-escalating anger is not something that's particularly hard, but it is hard if you don't have the tools in your tool belt. And I think for social work students in particular, one of the hardest things about the clinic is that the clinical work that we do really is very brief, and it's hard to train somebody on this sort of very rapidly engaging with somebody and assessing at the same time, and then having an intervention and having it very truncated like a microwave. It's a challenge.
That's great. Okay, so we have a question from Dominique, who's going to go ahead and ask it. So let's unmute you. You can unmute yourself. Okay, go ahead.
I unmuted it. Thank you.
Yeah.
So I thank you so much for everything that you shared, because I have friends who worked at the clinic and had good experiences. So thank you for sharing that with us. You mentioned that uncomfortability versus harm. So I wanted to hear more from you about when you do have students of color going in, because it wasn't specific as to if this racist comment was said to a person of color or not. So I'm wondering if you all have anything put in place, or any type of mindfulness around if a racist comment is said to someone of color. So if me as a Black woman, someone saying that this is something that all the Black people are on, it is going to impact me differently than it would a white student. So I'm just wondering if there are any things that you all have in place, or conversations that are had, because I often hear that in the school, or heard that in the school of social work, where it's like, oh, we need to be comfortable with being uncomfortable. And a lot of the harm done often disproportionately impacted students of color.
It's an amazing question. And I appreciate you asking for it. And I don't have a system figured out to support students of color if this comes up. That, I think, was the conversation that we had as a class separate from it. In this instance, it was a white person saying that to a white person. And that this tension between uncomfortable and unsafe, or uncomfortable and harmful, it's a real tension. And I think that, my takeaway from your question is really that I want to figure it out. And I don't think I have the answers. And I actually think that, like, historically, white people have done a terrible job of creating those spaces that support everybody. And yeah, I think that one of the challenges with social work is that it's not for the faint of heart. And as a former manager, there's a difference between putting up with situations that are challenging and hard or something gets unsafe. And in my past life, I was never able to figure out, there's some things that are very, very obvious. Physical violence is obvious and challenging and horrible. Racism is like up there. But like, is that the bright line? And I don't know the answer to these questions, and I don't know how you're all receiving that response. I think that it's different people have different capacities, and I think my takeaway from your question is trying to figure out a way that supports everybody in their individual place. And I kind of was, as I'm talking, I'm thinking of some of Daicia Price's responses to this mess of overt racism, systemic racism, white supremacy, and how over time your own individual threshold could change. But this just makes me think as an instructor, at this institution, what are the things that I could do to support students in the endeavor?
Thank you.
No, thank you for asking that question.
Thank you, Rick, and thank you for that question. I wanted to read out something that Daicia Price has put out there. She said, and this is specific to the comment about why isn't there a free clinic in Detroit? And she said, so creating a specifically student-run clinic has been something that leadership hasn't started. Also, Wayne State University students have provided a lot of student-driven healthcare services. So UM is trying to be mindful of that as well. So that's really helpful to know. Thank you, Daicia. Okay, so speaking of solution focus and student-run care, I'd like to introduce our next speaker, who is Dominique Crump. She's a recent graduate, and she's also a member of the Engage team. And we know that, there's a lot going on right now. Some of us are personally impacted by the trauma of racism and discrimination. And we also know that self-care during this time is an act of resistance as well. And it's important to take care of ourselves. So Dominique, she is going to lead us through some exercises around self-care. So take it away, Dominique.
Thank you. Could we go to the next slide, please? So I'm really happy that I get to talk to you all about self-care during these sessions. In my last segment, I talked a lot about discipline and how discipline is a huge part of taking care of oneself. And I think it's a part of self-care that sometimes we conveniently leave out because it's more fun to indulge in the pizza and the spa days and the ice cream, which are great. That is no judgment. Those are all, I name things that I like. And also having a routine and making sure that there are certain areas of our lives where we're taken care of is a huge part of self-care. So we've discussed all types of tools such as the DBT Please skill, box breathing, mindfulness, yoga, meditation, and so much more. So I encourage people to revisit those. And then also with that, there's sometimes you don't know where to start. So if you're looking to add some structure to your day to ensure that you're caring for yourself proactively versus reactively, the Berkeley Wellbeing Institute, which is not affiliated with UC Berkeley, they made that very clear on their website, has a well-being quiz where they ask you to take the quiz and they'll send you a personalized report based on your answer. So I took mine, definitely got a good detailed report back, and they let you know what domains in your life may need some more attention. So when this goes out, if the PowerPoint goes out, that is hyperlinked to that slide. So if we go to the next slide, please. There is a Psychology Today article that broke down 12 steps to take better care of yourself. Oh, sorry, it was hyperlinked to the whole thing. So if you go back to the actual presentation, I didn't know it was going to do that. So my apologies. There is a Psychology Today article that broke down 12 steps to take better care of yourself. And I switched them into questions that we can ask ourselves. So there are 12 questions, and just like we wouldn't ask clients to meet all of their goals and objectives in one session, please do not put any pressure on yourself to master all of these things in a week or even a month, especially if you haven't been working on them already. So I'll go over just the first 4 today, and then over the next couple of sessions, we'll go over the rest of them. So the first question is how you're sleeping. And some of the questions that you may ask yourself is, do you have a bedtime routine? Are you getting enough sleep? Are you eating or drinking directly before bed? Because sleep can have a huge impact and effect on how we feel emotionally and physically, and not getting enough can even cause us serious health issues. On top of that, stress and other distractions can wreak havoc on your sleep. And if you're eating or drinking before bed, keep in mind that caffeine and sugar tend to keep you awake. So I'm someone who sometimes has a problem going to sleep in complete silence. So the applications Insight Timer and Liberate have a bunch of different tools. So Insight Timers have meditation tools, but also bedtime stories for adults. And the Liberate app has all people of color who are providing meditation. So a lot of times on these meditation apps, you are hard pressed to find a Black or brown person. So what I appreciate about the Liberate app is that it is all Black, Indigenous, and people of color. And so the next question is, how is your gut health? Your gut health can have a significant impact on your health, well-being, and vitality. The types of food that you eat impact the bacteria that live in your stomach, resulting in either positive or negative outcomes. An unhappy gut can lead to an unhappy person and vice versa. So speak to your primary care physician more about this if you want to learn more. In my personal experience, adding certain things to my diet, like kombucha and probiotics, has made a huge difference. But those are definitely things you should talk to your primary care physician before just often buying probiotics or drinking a bunch of kombucha. Those are just some personal examples from my life that I have to share. The third thing is, are you sedentary more days than not? So daily movement can help you both physically and mentally by boosting your mood and reducing stress and anxiety. Walking for even just 30 minutes a day can make a huge difference in how you feel. Dancing in your room is an option. Yoga, there are video games that you can play that keep you moving. Get creative. This is about how you want to move and creating a routine that works for you. And then the last one that I'll talk about today is, does your diet support your well-being? The food that we eat has the potential to either help keep us healthy or make us alert and sluggish, make us sluggish and tired. So certain food can help our short-term memory stay sharp or decrease internal inflammation, both of which have long-term effects on the brain in turn the rest of the body. So some of the most amazing self-care foods that were listed on the article are fatty fish, blueberries, nuts, green leafy vegetables, and things like broccoli. So I'll go over, like I said, the rest of the list of 12 things in the next couple of sessions. But I thought it was a really good article to help figure out ways to make self-care a routine and a part of every day, and not just a reactive something that we're doing if we're feeling bad, but really a part of our everyday lives. So thank you all, and I look forward to sharing the rest of these with you over the next couple of weeks.
Thank you, Dominique. So we're going to hand it over to Trina now, who's going to talk a little bit about next week.
Yes, so thank you, Dominique. Thank you to all 4 of our speakers, including Rick, Sophia, Andrea, and Daicia. We appreciate all the work that you do in sharing with us today. If you're still looking for volunteer opportunities or ways to supplement your field hours, we have the volunteer opportunity list, which is on this link. I think we'll also be put in the chat, and will also be found on our website. If you volunteer, we have a form you can fill out to share what you've done and how that experience was for you. And then we have an archive of all of the sessions that we've had here with our Engage Thursday webinars. So from the very first one we had at the end of March until today, at least in a couple of days, we have the days up to. So you can look at all those if you missed one or want to look at some of the PowerPoints or information or videos. I want to remind people that you can get field credit for these sessions, particularly if you check in with your School of Social Work field instructor to make sure you're getting credit for this. You also get credit for attending this session. I'd like to remind all of us that next Thursday, July 2nd, we're not having a Thursday session. We're starting up again on July 9th, and that will be a session called From Protest to policy let me start again. July 9th, from protest to policy reform, the legislative fight against police brutality. And so we have student activists and elected officials joining us. Look for details and emails, and things will be advertised in the near future where you can get an RSVP link. And actually our last 2 sessions will be somewhat related to police brutality and the criminal justice system. So please check in on those 2 dates. So thank you so much for being with us, staying with us, and have a great week. Bye-bye.